Good afternoon, everybody, and thanks so much for joining us on the final part of Mr. B's Frailty journey, Sliding Doors End of Care. This session will be presented by Joe Brady, Consultant in Palliative Medicine, and Sharma Mani, Consultant Physician in Geriatrics, both at Barnet Hospital. Before we begin, we have a few simple housekeeping points to cover. This session is being recorded, and the recording link will be shared with you via follow-up email tomorrow. All attendees are muted to avoid background noise during the recording. If you have a question, please type your question into the question box and Joe and Sharma will answer them at the end of their presentation. Once the webinar is finished, you'll be directed to a short survey of 6 questions. We would appreciate you complete your feedback as it is important to us. Thank you, and I'll now hand over to you, Joe, for the presentation.
Thank you very much. So welcome everybody to the final frailty journey in relation to Mr. B and his COVID. I'm aware that some of you might be joining for this session only, and that's fine, it can stand as a lone session. And some of you may have dipped in and out of the previous 3 sessions. My intention is over the next 20 or so minutes is to talk through a recap of Mr. B's story and share with you some of the things that we learned along the way in relation to end-of-life care and COVID, and share some of the evidence and resources, and then there will be an opportunity for questions via the chat box at the end. So to introduce Mr. B, he's an 86-year-old gentleman who met his wife, Mrs. B, at a dance hall. They were married for 60 years, but sadly she died 3 years ago. Since then, he's lived alone. He has no package of care, walks with a stick, and was going out shopping with his daughter. His past medical history is hypertension, type 2 diabetes, and he wears a hearing aid. Lockdown has been very difficult for Mr. B. He's felt quite lonely and quite isolated, and he has managed to master the art of FaceTiming his daughter. And we felt he had a clinical frailty scale of 5. Unfortunately, in April, Mr. B became unwell with reduced oral intake and fatigue. At that time, he had no cough, shortness of breath, no gastric symptoms, but he was unwell enough to present to hospital, where they found him to be dehydrated with an acute kidney injury and delirium. In session 1, we covered a typical presentation of COVID in the frail elderly population. He was swabbed and treated with fluids and oxygen. In session 2, we talked about treatment escalation plans, and after discussion with Mr. B and his daughter, it was agreed he was for active but ward-based care with no plan to escalate to ITU or CPR. And I just want to pause here for a moment to think a little bit about the importance of parallel planning. For Mr. B, we were still hoping that with supportive care he would recover from COVID, but we also recognised that he was sick enough that he could die. And that is the time when you need to be considering parallel planning, hoping for the best but preparing for the worst. So we'll often talk to patients and say, look, we hope things go well and we'll ensure you get all the appropriate treatments. But while holding on to that hope, we also need to consider what needs to be in place in case things don't go as we hope. The reason this is important is an observational study of over 20,000 people with COVID who were sick enough to require hospital admission. It revealed that 26% of those patients died. And certainly where we work here in Barnet, where we serve a very large frail elderly population, that number for us was significantly higher. And hence why you need the parallel approach to managing people with severe COVID, both in the hospital and the community. We do aim to cure sometimes and relieve often, but it's important to comfort always. Evidence shows us also that symptoms can escalate rapidly in COVID. So in an early case series from Wuhan, the median time from the first onset of symptoms to breathlessness was 5 days. And an Italian study showed that the median time for onset of symptoms to hospitalisation was 5 days, and from onset of symptoms to death was only 9 days. And that's why it's very important to take an anticipatory approach to symptom management for people with severe COVID. I would therefore encourage people who are looking after people with severe COVID to create a holistic urgent care plan, whereby a palliative approach runs alongside the acute medical management. and that symptom management approach focuses on things about ensuring that people are comfortable regardless of the outcome. So looking at things like anticipatory medicine prescribing, both oral and subcutaneously, looking at people's wishes and preferences. Have they got LPA, an advanced decision to refuse treatment, previously expressed advanced care planning? Have we considered what their preferred place of care is, or even their preferred place of death? And are we communicating with patients and families? We should be talking to people and saying things such as, look, knowing what you know of your situation, is there anything else important to you at this time? And who should we be in contact with in the event that you become more unwell? And we should be ensuring that those contact details are clearly recorded. We did cover communication in webinar 2, but just to recap, it's very important that we use clear language where there can be no misunderstanding about what we're saying. And I know it was very difficult, numbers were overwhelming, but where possible to ensure that communication is in a timely manner. Here's an example of a board that was created on one of the wards that enabled staff to keep track of who had spoken to whose relatives. And of course, if somebody is deteriorating, we need to review the frequency and urgency with which we're communicating with families. We've previously talked about the challenges of communicating whilst wearing PPE. There are also challenges when the outcome is so uncertain because it's such a new illness. And the challenge when somebody deteriorates so rapidly that we don't have time to build a relationship with them or their family to explore what's important to them. In terms of telephone communication, obviously we would always do everything we could to facilitate communication between patients and families, but often we would be leading those calls. And I would encourage people where possible to try and find a quiet and calm environment. Take a moment before dialing the number to collect your thoughts and focus. Consider, how is the patient now? What are we doing for them? What might the worries be? Clarify who you're talking to and who it is you're speaking about. Acknowledge just how hard it must be for people waiting at home to receive these phone calls. Acknowledge how distressing it must be not being able to see their loved one. But then try and build connections. Find out, who is Mr. B? Find out from his daughter, what does he like? What does he dislike? Who is this man? What's important to him? Try and build a picture of who this gentleman is. And thinking, is there anything that's important for this man as an individual? This slide is taken from a BMJ article in last week's BMJ, and you will have these slides so you can review this at your leisure later. But I particularly like the opening hope and worry statements. So we're doing all we can, and we hope Mr. B responds to treatment, but we are worried that he may continue to deteriorate despite our best treatment. So thinking now about, what does the evidence tell us about symptoms in people with severe COVID? So this first article showed that the most common symptoms were breathlessness, cough, and fatigue, things that we're familiar with. Another case series looking at patients who had been referred to the hospital palliative care teams found the most common symptoms we were asked to address were breathlessness, agitation, drowsiness, and delirium. We also at Barnet Hospital discovered people who were hypoxic and were having hypoxic seizures, and we adjusted our guidance accordingly. In relation to these symptoms, in terms of how we manage them, well, it's business as usual. So it's things like using opioids for people who are severely breathless at rest or on minimal exertion, or Oromorph if they can swallow and subcutaneous if they can't. The case series found that the doses were not different to normal. A medium dose range was 10 milligrams over 24 hours. One thing we did notice is there did appear to be different trajectories in COVID, and there were those patients who appeared to present with symptoms and deteriorate incredibly rapidly, that it forced us to be bold with our prescribing and ensure that people got stat doses in addition to continuous drivers to ensure the symptoms were addressed in a timely way. In addition to non-pharmacological measures, normally we would recommend fan for breathlessness, but that was to be avoided because of droplet spread. So as an alternative, we do know that cool wipes on the face trigger the J receptors, and that relieves the sensation of breathlessness. I know that in ITU they were proning patients as part of their recovery, but there is no evidence to support proning for palliation. But if a patient feels well enough to adopt that position and they feel comfortable, then that's quite reasonable, but it's not something I would necessarily recommend. The evidence regarding oxygen shows very clearly that oxygen may relieve breathlessness in the presence of severe hypoxemia, but it does not help if there is no hypoxemia. If we think somebody is dying, it's important that we focus on treating the breathlessness, not the oxygen levels. So some people were recorded as being very hypoxic, but they did not feel breathless, and therefore I wouldn't have been using oxygen, as it's just another burdensome treatment. So we really need to take an individualised approach. This is also very important in a non-hospital setting, as local guidance needs to be looked at in terms of oxygen availability in the community. The other symptoms that we came across were agitation and anxiety, and that's quite understandable because of the physical distressing symptoms such as breathlessness, but also the fact that people were isolated and separated from their families. They were frightened that they might die, and they might die alone. And they were being cared for by people in PPE who looked like they'd come from an episode of Breaking Bad. I think all you can do in these situations is acknowledge this and address what you can, so enable them to call and contact their family. We were often wearing photos attached to the front of our PPE to show the human face behind the PPE. Reassure people that we're doing all that we can. Reassure them that there is medicine there to ensure that they're comfortable, but acknowledge that yes, we hope we can help them, but we are aware that there's a chance that they might die and that we're doing all that we can. We know opioids are useful for breathlessness related to hypoxemia, but we also know that when people get breathless, they tend to get very anxious. So they may benefit from the addition of benzodiazepines for the associated anxiety. And then if you have somebody who is delirious rather than just anxious, and they are agitated and delirious, sometimes they might need an antipsychotic such as haloperidol, either in addition to a benzodiazepine or instead of. So back to Mr. B. At the end of session 2, he was a bit of a crossroads. And in session 3, Mr. B actually recovered and went on to have rehabilitation. But this is the sliding door moment. And in this session, unfortunately, sadly, Mr. B got worse. So we're now at day 5 of admission and 9 days since his symptoms began. He's confirmed COVID positive, and sadly, he's getting worse despite maximum supportive care. He's not eating and drinking, he's on fluids but getting overloaded, feeling more breathless, feeling tired with increasing oxygen requirements. And he says he feels he's had enough. He feels sick enough to die. And actually, he said, I want to go and dance with my wife. She's waiting for me. Here I think Mr. B was naming the elephant in the room. He knew he was dying. And actually, by us being able to name that with him, it gave us the opportunity to ask him what mattered. What does he want? This would normally be a time where we would be talking to people about where they wish to be cared for and where they wish to die. But just asking somebody doesn't mean we can promise to achieve that. This study on changing patterns of mortality showed us that according to the data available, 65% of COVID deaths happened in hospital, 28% in care homes and 70% elsewhere. Much higher, and this reflects the fact that we weren't testing people in the community. But the key point is people can deteriorate very rapidly from COVID, and we may not always be able to facilitate a rapid discharge home when people recognise they're dying. So we need to ensure that we have good end-of-life care regardless of care setting. This paper also showed us the amount of increase in death rate in each care setting. And we know from the media that care homes have really been dramatically hit by the increased death rate, which has increased by 220% in care homes compared to their baseline, 77% in home deaths and a 90% increase in hospital deaths. But actually the hospice death rate has gone down, and that we think is related to the restricted visiting policy, which makes hospices a much less attractive place to be considered. So if somebody is dying in hospital from COVID, the things for us to think about are decisions about level of care. And by that, I mean, should we be continuing routine observations, blood pressure, pulse, or do we switch now to focusing on end-of-life care observations? Does this person look comfortable? Are they in pain? Are they breathless? Are we doing bloods? Are we reinserting cannulas? We need to be mindful that physical contact is likely to be very limited between staff and the person who is dying. Here we did our best to facilitate visiting, but it was restricted to only one person visiting when we recognised somebody was in their last days and hours of life. And because of concerns about the effectiveness in PPE, it was restricted to people who were over the age of 12 years old. One of the things we did focus on was technology, using iPads and volunteers to facilitate as much communication as possible between family members. And we were also aware that we needed a human touch. So one of the things we introduced was stone pebbles in heart shapes, where people could write messages, and they were placed in the hands of people who were poorly. And then after they died, we put them in sealed bags, which could be passed on to the relatives. Obviously, when the person dies, we need to inform that relative, and it's been primarily done over phone. And it's worth taking a moment for yourself before and after these conversations to take a breath. These next 3 slides are just some useful resources about breaking bad news that somebody has died over the telephone, but I'm not going to go into them in any detail right now. In terms of looking after people at end of life in the community who are dying of COVID, one of the first concerns we had was about anticipatory end of life medication. We were very aware that we were anticipating an increase in the number of people dying in the community, but we were also aware there might be reduced staff to support that, as staff would be self-isolating, becoming poorly themselves. So there was going to be a gap. So we had to think about who was going to administer end-of-life medicines. Sometimes we looked at our policies, and we did on occasion train up and support family members, usually in the hospital setting, to then go home with their loved one to be able to administer medication. We also created non-parental alternatives, and there is a resource at the end of this slide set showing that. That was to be used only if there was nobody available to administer medication, because the evidence for this is less robust. We liaised with our paediatric colleagues to get advice from them, but we're less familiar with these medicines, which increases the risk. We also had to look at accessibility to these medicines, and we worked very closely with our pharmacy colleagues to ensure that there would be ongoing supplies to medicines. They kept an up-to-date list for us, updating it daily, telling us which chemists were open, what opening hours they had, and we're asking those chemists to ensure a robust supply of end-of-life medication. Nationally, a new policy was created around drug reuse in the care home and hospice care setting, because there was worry that we might run out of end-of-life medication, and we're in the process of trying to roll that out locally. So if end-of-life medicine had been prescribed for one patient and it was no longer required, then that medicine could be reused for other patients. In relation to care homes, obviously it's well publicised all the issues with access to testing and admissions, and the risks to other residents, and the issues around staffing, staff moving from one care setting to another, reduced staffing numbers. There was also issues with access to other healthcare professionals. In primary care and in the community, we had limited access to PPE early on, which meant many healthcare professionals were not able to enter care homes. And certainly where I work, the majority of care homes closed their doors to any external visitors. From the 1st of May, it was recognised there was a real issue with care homes, and the government mandated an enhanced care support model. And I know that might vary locally, but we've put a huge amount of work in locally in Barnet with trying to support that model. Like I've already mentioned, access to PPE was a huge issue, particularly early on in the COVID crisis. Hospitals were prioritised, and understandably so, but what that meant was we had no PPE, which meant we either visited but at our own risk, or we didn't visit at all. Certainly where I work at my local hospice, we put out a social media campaign, and we had many masks donated to us from dentists, nail bars, people made visors for us, an amazing response from the community. Another practical issue was access to oxygen. So oxygen in the community has been tightly controlled for many years and restricted to those patients who fulfil certain criteria. We reviewed guidance at a pan-London level, and it was agreed that oxygen could be requested on an individual basis for somebody with COVID who was hypoxic and breathless, but there's no guarantee that that can be arranged quickly enough. What they were not willing to do was to consider allowing organisations to proactively secure concentrators that could be used if and as and when needed. They felt that the governance framework was not safe enough to support that. Some other issues: many families were willing to look after their loved ones at home who were dying. Some wanted carer support, and it was variable as to whether or not that was available because of staffing issues. But some people did not want carers going from home to home and bringing that risk into their home. So many families were left home alone caring for their loved one. So we did all we could to support them practically, giving them advice and guidance emotionally and spiritually. It's been a real roller coaster emotionally in the community. And also, I think early on there was an assumption that anyone who was frail would die from COVID, but that's certainly not been our case. So it's been quite a roller coaster. Other factors to consider in the community: death certification changed. It became a remote process, and they extended the time frame from 14 to 28 days and allowed video assessment. And that's been a really useful change for us. More controversially, with changes to verification of death. Historically, it's been primarily primary care doctors, ambulance and police who confirm that somebody has died. But like I mentioned, PPE issues meant that we had limited people who were able to safely go and verify death, yet we had more deaths. In London, they created a specific team to try and address some of that gap. Policies have been written trying to support staff remotely. So in care homes, if a resident has died, the care home can contact 111 who talk them through formal death verification. And Hospice UK have released guidance on nurse training for verification of death, and we're working locally with our district nurse and palliative care teams to support that training. So back to Mr. B. Sadly, Mr. B died comfortably in hospital. His daughter had been able to visit because it had been recognised that he was in the last days of life, but she wasn't present at the point he died. He did hold one of the pebbles in his hand with his wife's name written on it, and that was passed on to his daughter, which actually became hugely important to her for her bereavement. In relation to bereavement, many of you may be familiar with this trajectory slide, and that new yellow line is COVID. COVID has changed the face of grief and bereavement because it has come so suddenly, unexpectedly. It feels brutal and people are on their own. They're experiencing not just the loss of life, but all the losses related to the social distancing restrictions. So loss of human contact and touch, not being able to be with their loved one at the end, not being able to attend funerals, and not being able to seek comfort in the arms of others. We can't fix these things, we can't change them, but we can offer empathy, kindness, and acknowledgement. We can listen and walk alongside people facing difficult bereavement journeys. One study, early study, is showing there are additional risk factors for poor bereavement related to COVID. So if a patient experienced unmanaged severe breathlessness and were very isolated, and then the person left behind has a limited network, it increases their grief risk factors. We can try and mitigate that by facilitating opportunities to say goodbye, proactively palliating symptoms, and providing emotional support. And finally, I just want to end with one slide on self-care. I think it's very normal to have an emotional reaction to what we're seeing at work. Many services are not familiar with seeing this number of people who are dying, and it can cause huge anxiety for oneself and colleagues and families. I think it's important to acknowledge that and enable others to acknowledge it. I would encourage people to look at their own normal coping strategies, what works for them, taking regular rest, exercise, taking time for self. But where they're struggling, encourage them to seek additional help and guidance. So that is the end of my presentation. There are a further 12 slides with additional resources and references, and you will be getting access to these slides. But now I would like to open to questions. So if you do have a question, please type it in the chat box, and I'll do my best to answer any questions that you may have. Thank you for listening.
Thank you very much, Jo. As Jo just mentioned, please type your question into the question box for her to answer. If you do think of a question following the close of the webinar, please email it to frailty@nhselect.org.uk. That is frailty@nhselect.org.uk, and I will forward it to Jo.
Thank you very much. I'll keep my eye out to see if any questions appear, but in the meantime, I can just show you some of the resource slides. So I've referred here to the NICE guidance, some communication guidance. The Association of Palliative Medicine had a really useful article. Okay, question in. Is it possible to have a webinar for community nursing staff on verification of death? That's a really good question. I know that the guidance has been written by the Royal College of Nursing and Hospice UK, and then I think that locally organisations are looking at delivering that. I certainly know the hospice I work at, North London Hospice, is looking to deliver remote training for in-house staff on verification of death. Whether or not that's something that we could provide through an organisation like this, I can certainly look to see if it's possible. Obviously, I don't know where you work. One suggestion would be to contact your local hospice and district nursing service. So I know where I work, our district nursing teams are leading their own training, and the hospice is doing the training for our in-house staff. So I could look to see if that's possible. And in the meantime, I would suggest you contact your local palliative care services. How did you self-care during this difficult time? That's a really good question. I'm over divulging here, but I'm married to an ITU consultant. So he obviously, in some respects, took priority in terms of the number of hours that he was working. He was working 16-hour shifts. And so because of childcare, it meant I had to go home at the end of the day. And actually, I think that was probably very helpful for me. And I think that it enabled me to switch off. I exercised. I walked. I normally run, but I got COVID myself and my lungs took a bit of a battering. So I think for me, it was trying to be boundaried, trying to spend time focusing with my family, trying to allow a bit of normality. It was taking some exercise. I've taken up yoga, which I've never done before, just on an app, a free app that I found. And talking to my colleagues at the hospice. We've been doing Schwartz rounds to reflect, and they've been quite emotional, but really useful. So I think one of the things I would encourage you to do is think about, how do you normally cope? You probably already have some inner resources and strategies that you can use. So look to that. But then there is a huge amount of useful resources available. Actually, the last couple of slides, if I flip through to that, these were two slides that my social work colleagues prepared for care home staff. And this was really guided for care home managers to give them suggestions as to how they could support their care home teams. But there's some things within this that might be quite useful.
Thank you. We'll just give it another minute to see if any more questions will come through.
There's a comment here. This has been so helpful and informative, and I feel it should be mandatory for all community staff to attend Frailty sessions. You're speaking to the converted, and we do completely agree with you. The reason we did this session around Mr. B, and we did it remotely, and we did short burst sessions, is because we knew everybody's very busy and time pressured at the moment. We do ordinarily run a full day session, taking people on the whole frailty journey with Mrs. B, who I referred to earlier, Mr. B's wife, who died 3 years ago when we started running this training course. We do hope to continue running that course. Obviously, we are London based, but we would welcome anyone to attend. And I wonder one day if we might hope to find a way to run Mrs. B electronically. But yes, I would encourage staff to attend, and you will get a link to this. So I'm not sure if I'm allowed to say it, but please do encourage people to have a look at your link in these sessions. There's another question here. What would you do anything different knowing what you know now? I think that prior to the wave hitting, we were very, very anxious about the anticipatory prescribing. And certainly before we started seeing patients, I spent a huge number of evenings working with colleagues trying to create anticipatory guidelines for non-subcutaneous drugs. And we started ordering for every patient anticipatory subcut and non-subcut drugs. In reality, for us, despite London being hit quite hard, we never really needed to use it. So after a while, I suppose, come about May time, we stopped requesting the non-subcutaneous medicines. So I think that fear and anxiety was driving some of our processes. And what we tried to do was continuously check with ourselves. It's a little bit like the development of the Nightingale hospitals. There was a fear and concern and modelling suggesting it might be needed, but then it wasn't. I think it's a success if something wasn't needed. I'm pleased we didn't need to get relatives giving medicines. But that was certainly one of the things that we did and then hasn't really been materialised.
Thank you, Jo. Just to confirm, I will be emailing the link to today's recording and also the slides to everybody this afternoon. Well, I think that was the last question. Thank you very much, Jo, for taking the time to present us with this webinar. And thank you everybody that's followed us on Mr. B's Frailty journey.
Yeah, thank you very much.
Thank you very much. And that's a goodbye from both of us.